Hello. Welcome to the project How Epidemics End, which is based at the University of Oxford. My name is Erica Charters, and in these videos, I discuss with researchers how they understand and analyze disease, as well as how they measure and understand the ending of epidemics. Today, I'm here with Lorenz von Seidlein, who's an associate professor of epidemiology at the University of Oxford. He's also part of the Mahidol Oxford Tropical Medicine Research Unit, which is based in Bangkok in Thailand. Lorenz, what drew you to epidemiology and to your field of infectious diseases?
I was always kind of interested working in places like Africa and Asia. And I realized early on that the large majority of people in these countries are under 18 years of age. And the bulk of the diseases, if you work in a hospital, are infectious diseases in children. So to get the best training for that work, I thought it would be a good idea to get training in infectious disease, in infectious diseases, how to treat them. And then when you do this for long enough, you realize that you would like to prevent these diseases and find out a little bit more about them, not to sit there every day and treat malaria or treat otitis media, but to think about, how can I improve the treatment, but perhaps even more importantly, prevent children from coming in with these diseases. And then if you think about how do you do that best, you end up that you would like to do clinical studies, clinical trials, and to do this really professionally, to do it well enough that you get funding for it and that you can publish it, you need some training. And so I decided I would really like to get training in infectious disease epidemiology.
So I think most people now probably know, thanks to COVID, about epidemiology, and they know that this means studying disease among populations, among large groups of people. But there's a variety of ways in which epidemiologists study disease. Some people do field work, some people just deal with statistics. What kind of evidence, what types of sources do you use when you're conducting your research?
And we do a lot of surveillance study to find out how the diseases are distributed. And then we try to do blinded randomized controlled trials, which is really the best evidence to see whether an intervention works or whether it doesn't work. That's what we're doing. And we're doing this usually in countries where these diseases are, which are called neglected tropical diseases. And that's in low-income countries in Asia and in Africa.
Mm-hmm. And so basically you're looking at very large numbers when you do your clinical trials, large groups of populations, and in some ways comparing and contrasting treatments as well as tracking disease rates. Is that right?
If you want to get an understanding how a disease develops in a population, obviously you need huge surveillance. And the more people you enroll in a study and the broader your surveillance is, the higher the certainty is that your results are relatively correct. So that's why we would like to do massive studies. On the other hand side, what is counterintuitive about it is because if you have an idea and you would like to test it, ideally you would like to do this in a small setting in the first place and not risk too much, right? Only in 100 people. But if you do a small study in 100 people, it's not very generalizable and there's a lot of uncertainty. In contrast, if you do a study in 10,000 people or even in 100,000 people, you can detect a very small effect with high precision. That's why you would like to do it in massive populations, basically. The problem is that if you do it in a massive population, you need a completely different logistic setup. You need people who collect the data, who can work with data, who can do statistics, and so on. And to do this, you need a lot of funding to pay everybody, basically. And then to get the funding, you have to enter the politics to get the funding. So it becomes really, really much more complicated. So on the one hand side, you would really like to do something small and cheap and quick, but on the other hand side, to do it with high precision and to get it right, you have to do it massively and big, and it takes a long time.
So I know you've looked at a range of diseases when you're thinking about disease among these large populations. You've looked at malaria for a long time. Most recently, you've looked at COVID. You've also worked on cholera. And as you mentioned, these are considered, they're sometimes called neglected diseases. What does it mean to be a neglected disease? In what way are they neglected?
It's a little bit difficult, and I don't know the history where this word comes from, the word neglected diseases. I didn't look that up and research it well enough. For me, it came mostly that a lot of doctors are drawn to people who have a lot of money, and the richest people, the most affluent people, have cardiovascular diseases, for example. And so there's a lot of money for research in that field. And then everybody who works in other diseases, like, for example, infectious diseases in children in low-income countries, of course, thinks, well, in comparison to these guys, I'm neglected. And then there was a journal of plus neglected diseases. And so it became very clear that a certain group of diseases belongs in there. And who defines this is another question. And then the other development was that after 95, between 95 and 2000, Bill Gates came into the field and suddenly had a lot of money. And he said, I'm investing money into neglected diseases. So suddenly it became particularly attractive to have that label because you could apply for funding from the Gates Foundation for that. And so these multiple influences are taking place at the same time. So a lot of people are saying, well, my disease is a neglected disease. And there's no, your disease is not a neglected disease. You're wrong about this. So it has changing. It's a little bit fluent. But I think both cholera and malaria can be still labeled neglected diseases, even so there are billions of dollars and have gone into malaria in the last 20 years.
I mean, my other sense is when we think about where those diseases still occur, even though they were common throughout much of the world, by the end of the 19th century and really into the 20th century, malaria and cholera are diseases we only really see in the developing world. We don't see them so much in industrialized worlds. So they tend to be diseases that are tied to poverty and just certain geographies as well. So for people who don't know, can you explain a bit about a disease such as cholera, which is very often linked to wars and to poverty and to a lack of infrastructure? How does it spread? What are its symptoms?
You know more about the history of cholera than I do because you're an historian. For me, it kind of sort of started 1970s, 1960s, when the home of cholera was really considered the Bay of Bengal, particularly Bangladesh, that was considered the homeland of cholera. And then it has been, over the last 50 years, increasingly controlled in Bangladesh, so there isn't so much there anymore. But then it has migrated to Africa. Then there was an outbreak in South America, Peru particularly. Then there was a massive outbreak in Haiti, and now probably the center is Yemen, because there's a war going on, and that has destroyed the entire water supply and sanitation. And there are a lot of cases now reported from Yemen, probably more than from anywhere else. So it's outbreaks in different places, but there was a clear shift from Bay of Bengal towards sub-Saharan Africa, because in Bangladesh, I assume that the water supply and sanitation are improving to a level which is no longer sustaining cholera transmission, but you have a good environment for that in sub-Saharan Africa.
So very much tied to water supplies, to sanitation, and in some ways to basic hygiene.
And that's, well. I mean, water supply and sanitation for most people comes even before internet, believe it or not. It's probably with social media on the same level, as important. And so a lot of people, when the first thing is that you have a roof over your head, but then you get a safe water supply. And a lot of people need help with this because it's not easy for yourself, if you have nothing, to get to safe water supply and to sanitation.
And I know that you're actually working on, or you're part of what is a global program right now to eliminate cholera. So how will you know, as an epidemiologist, how will you know when cholera is eliminated? What things are you measuring?
So what you do is, for example, what we did in Mozambique, in Beira, during the surveillance for a trial where we tested this killed oral cholera vaccine, is we are looking every day how many cases are reported in our reporting system. And then say you have every day 100, 120, 140, 150, and so on. You see that it's slightly going up, it is increasing. And then comes a point sometime, and we can talk about why it has to go down again. Then it slowly goes down, and then at some point you have 50, 30, 40, and then you have only 1 or 2 cases, and then finally you have nothing anymore. And that it's pretty predictable and it happens like this. So, but it can still happen that there are some time out that there is still, you know, there are 5 cases in a week and then 2 and then 5 again. So it goes along. It hasn't really completely stopped. So if you really want to say, when has it stopped? You have to wait for a year and then look back at your epidemic curve and see when was the point when nothing was reported anymore for a full month, if you want to use that as a criterion. And say, okay, so this must have been the time point where it stopped. But while you are sitting there, you said, okay, this week we only had 1 case. It's really difficult to say that the outbreak has stopped because you can't predict the future. So it is something which you decide in retrospect. You look back and say, okay, this must have been the time point where it stopped.
But I imagine also it must be very difficult, especially if we're talking about outbreaks that often happen during wars, during breakdowns, to get reliable data. Is it easy to get data on cases of cholera?
Cholera is a particularly interesting disease because it's so stigmatized. It's associated with poverty, with the absence of safe water supply and sanitation, which nobody wants. So for a government to admit that they have cholera cases is a bad thing. And in many countries, particularly in Asia, governments wouldn't like to admit this. So they call them watery diarrhea cases and don't report them as cholera. It's not good for tourism, that's for sure. And it's not good for investment in the country. So the leadership, the government usually doesn't want to report it. On the other hand side, if you are in a war situation, in a really difficult situation, like for example was the case in Mozambique, you start thinking to weighing it up. Where do we get more money from? Development, if we report a lot of cases, or do we get more cases if we report no more cases and say cholera is controlled and tourism should come back into our country? So these are the 2 political influences which are sitting on you. But if you are a relatively independent researcher working in a place like in Beira, you can we had no problem reporting the cases that we found. But the cases that we find in a setting like this are only the ones which come to us. In that place, Beira, there was a cholera treatment center, and everybody living in Sofala province knew if you have cholera and you want to survive severe cholera, you have to go to this point. They won't let you into any other hospital because they don't want contamination in the other hospitals. You have to come to the cholera treatment center in the middle of town, which was exclusively dealing with watery diarrhea cases. And there we had these books, and everybody who came in was written into it. And the next morning, one of our guys would come in there, copy the names, and then enter it into a computer. So we would know every day how many people came into the cholera treatment center. But you rightly say, so what happens to the people who are in the field who either can't come into the cholera treatment center, or people who don't have enough money to get there or too sick to get there? Yeah, we miss them.
So as well as needing all this data and in some ways having centers such as that, what is required to eliminate cholera? What do we need to do?
So give me a second. Let me talk about, there's elimination, which is a geographical area when you get rid of it. And then there's eradication, which means you get rid of it from the whole planet. And people would like to eradicate cholera, which would be a great thing. But there are people like Rita Colwell who found that zooplankton, which is in the ocean, can become infected with cholera and carries it. And once you have an animal host out there, it becomes really difficult to think about eradicating it, because it's very difficult to imagine a situation that everybody on the world has safe water supply and sanitation. And if some person like this comes in contact with it, it will be there again. Cholera will get into the human population again. There's no question. You can eliminate it from a relative limited area with improvement of water supply and sanitation. That's the long-term strategy. What we did in Beira, for example, when there was a crisis situation, that we say in the first instance, we would like to vaccinate everybody now. We would like to do a mass vaccination campaign. And a lot of people understand now what I mean by that, because it's the same with COVID, right? So things have changed. It was a little bit more of an unusual idea 15 years ago. So you go in there, you tell the whole community, you know what cholera is, you're scared of it. We are bringing this cholera vaccine in here, and we're opening these mass vaccination centers, and everybody can come in and can get vaccinated. And that's great. And it really suppresses an outbreak. But the vaccine only gives you immunity for, say, 2 years, just as a rough measure. Then you are susceptible again after 2 years. So basically, you gain then 2 years where you should set up water supply and sanitation. If you don't do this in the 2 years, either you do a repeat annual mass vaccination campaigns, one approach to it, which is relatively costly, or you do something more permanent and really work on your water supply and sanitation and get that going in the time while this. But why you have herd immunity.
So, and I know that there's been a number, as you say, of these elimination programs thinking regionally, and I know that you're working especially in Southeast Asia right now. Some of the global programs for eliminating cholera started, I believe, back in the 1990s. So how close are we right now in 2021 to eliminating cholera in these regions?
Yeah, I think the big spanners in the work have been these huge outbreaks. Haiti was a huge one. And that was thought to be imported from a person from Asia working for the United Nations, for the what do you call these troops that they are sending with the United Nations, emergency troops. And they were stationed in Haiti, and the sanitation wasn't satisfactory. So the people were basically had their raw sewage going into a river, which then people used as water supply. And we assume that one or more of these people in this United Nations contingent was infected and transmitted cholera to the local people. So you can easily transport something from one place nowadays with a 12-hour flight to another place if sanitation at the other end is not satisfactory. If that person comes to New York, it's very unlikely that it causes an outbreak. But if the person ends up in Haiti and nobody has taken care of the sanitation properly, then you have another outbreak. The other that outbreak is now in decline, much better controlled. The big problem at the moment is Yemen, where there's a warfare ongoing. Saudi Arabia, the United States involved, and so on. Very complicated situation. And that was ongoing, and they report a lot of watery diarrhea and a lot of cholera cases there still. And of course, the underlying problem is that even if you construct a water supply system and sewerage and it gets bombed the next day, you have nothing. And that seems to have happened there repeatedly over and over and over again. So the solution for that is you can do mass vaccination campaigns to the point that there is that you have enough time to construct safe water supply and sanitation. That is probably the only way to deal with that, to solve that problem, to get control in Yemen over control. But nevertheless, I mean, there will be another outbreak, I would predict. So the chances of really eradicating it globally are not very high, I would think.
But I'm impressed that you're still working on this, and I wish you very well on your research as you continue to tackle diseases such as cholera and malaria. Thank you very much for sharing your expertise with us, Lorenz. And thank you all for joining us, and I hope that you'll join us with some of the other interviews and videos.